Welcome class to week 4. Today we are covering chapters 16 and 17. We'll be focusing on cardiovascular and peripheral vascular systems. So by the end of this presentation, I'm very hopeful that you will be able to achieve these three objectives right here, which is an integral part to prepare you for the clinical practice. So we'll begin our deep dive today into the cardiovascular system. We will cover anatomy and physiology, but we'll not spend much of the time into that. Our focus will be on the assessment. This is just a quick review of the anatomy and physiology to show you the primary cardiac structures. For example, you can notice the position of the right ventricle, which also forms most of the anterior surface of the heart. Uh, for example, the point of maximal impulse is typically located at the fifth intercostal space, midi-clavicular line representing the left ventricular contraction, which is you are already familiar with. So basically, this is just a quick review of the flow of the blood, which is very critical. For example, looking at the oxygenated blood, which returns to the right side of the heart and then gets pumped into, to the lungs. And then oxygenated blood, you see in red, which returns to the left side to be pumped systematically. The atrioventricular and semilunar valves prevent the backward flow during the continuous cycle. So most of the important events to remember in the cardiac cycle will consist of the systole and diastole. You already know systole is the period of ventricular contraction, which is marked by the S1 and S1 sound with the AV valves when the AV valves close. And then diastole is the period of ventricular relaxation and filling, which is marked by S2 heart sounds when the semilunar valves close. You are very familiar with these events in the cardiac cycle. And S1, S2, those are the normal heart sounds. This table outlines the chest wall locations where murmurs and sounds originating from specific valves are best heard. For example, aortic valve sounds are typically the loudest at the right second intercostal space, while mitral valve sounds are best auscultated near the cardiac apex. The electrical conduction system coordinates the heart's mechanical activity. The SA node, for example, will initiate the impulse, which travels to AV node, the second one on the slide, and then down to the bundle of His and through the bundle branches. So the disruptions in this pathway can manifest as arrhythmias on the EKG. So when taking a health history, pay close attention to concerning symptoms like chest pain, palpitations, and which often point to cardiopulmonary compromise. And we'll talk about pulmonary conditions, but usually they tend to go hand in hand for patients with cardiac pathologies. They tend also to have respiratory conditions at the same time. So we'll see that the blood pressure trends, for example, JVP, jugular venous pressure, or carotid obstructs, those require like precise auscultation of the heart. So these are the sounds that I already mentioned, like S1, S2, which requires practice, which you already have, and then a systematic approach to tell the difference between S1 and S2, and then noting the physiologic splitting, the split S2 during inspiration, and identify the systolic or diastolic sounds like S3 and S4 or other murmurs. So always characterize these sounds by their timing, intensity, pitch, and then the anatomical location. And you already know some of these sounds might be normal in some patients, for example, in athletes, in younger people or active patients. So maneuvers for systolic murmurs, for like squatting or any other hemodynamics may be altered, especially for those patients I mentioned who are very active. And then this may change the intensity of any specific murmurs. For example, standing decreases venous return, and which makes the murmur hypertrophic, cardiomyopathy louder, but decreases the murmur of the aortic stenosis. These are excellent tools, some of them to help you tell the difference between systolic murmurs. So as you advance your assessment as a GNP, health promotion is always the cornerstone of what we do. So we must actively work to prevent cardiovascular diseases by modifying or assessing and then modifying the risk factors. This is very important to promote healthy lifestyle changes. So basically, our early interventions are very important because they save lives, especially for vulnerable patients. So let's move on to another chapter, chapter 17, about peripheral vascular system. This includes the arterial, venous, and then lymphatic networks, which we'll review, and then what conditions they are associated with, like PAD, peripheral arterial diseases, and venous insufficiency. So this is just a quick review of the anatomy and physiology, which shows like a balance of hydrostatic and osmotic pressures for fluid exchange. And so when taking a history, it's very important to look at those classic symptoms of vascular compromise, such as intermittent claudication, limb swelling. You may notice those patients complaining of feeling cold in the lower extremities or losing hair, and some may present with abdominal or flank pain. So I mentioned some of the conditions that you may notice affecting the vascular system. One of them is PAD, peripheral arterial disease, which is a major marker for systemic atherosclerosis. So warning signs usually include leg pain, exertional leg pain, non-healing wounds, And we see most of these in primary care. And then also rest pain is the most common. And they may also complain of abdominal pain after eating lunch or dinner, uh, which may also indicate ischemia. So, for example, if a family history has abdominal aortic aneurysms, so that requires to be very careful, even with routine screening protocols. Arterial ischemia. Arterial ischemia. The location of claudication directly correlates with the site of arterial occlusion. For example, calf pain usually suggests a superficial femoral disease. It is also important to differentiate arterial issues from venous disorders like DVT or chronic venous insufficiency, another condition, or other conditions affecting the lymphatic system. When you are doing your physical exam, it's very important to assess the pulses, skin color, and temperature, and auscultate for any bluey over the carotids or abdomen, and palpate for any change in size of the aorta. Use superficial, special techniques such as ABI, ankle brachial index, which helps screen peripheral arterial disease. Another one you can use is Allen test, which is very important to assess blood flow to the hands. And then these are very important prior to radio interventions to have these tests done. As we aim to promote the health of our patients, we also tend to focus on preventive care. You may wonder, most important, the number one risk factors for all of these cardiovascular or vascular conditions, it's usually like smoking. So we can focus on smoking cessation, which is also the most leading cause for like peripheral artery disease or AAA, abdominal aortic aneurysms in older adults. So these are very, very important. Also, we can educate the patients on proper foot care, something they ignore, and then the benefits of walking programs to improve circulation. All right, so this is the end of this week's presentation. Just to review the recommended chapters, um, practice your skills in our weekly video assessments. And then if you have any further questions, just let me know. We can always exchange ideas and see how we can help you better. Thank you.